All right, welcome back. Our next talk is going to be on the treatment of non-small cell lung cancer by Dr. Schneider, who is one of the thoracic oncologists here at MGH. And we were just talking um, before this about how this must be one of the hardest talks to do every year because it changes so much in a year. You know, some of these things don't need to be updated that much, but this talk probably needs to be rewritten every year. So, Dr. Schneider, we're excited to hear your updates from last year.
Thank you so much, Dr. Frank. It's a pleasure to be here. So as Dr. Frank said, today I'll be talking about treatment strategies in non-small cell lung cancer. We'll go over updates in chemotherapy, targeted therapy, and immunotherapy in both early stage disease as well as in late stage disease. These are my disclosures. So this is our agenda for today. So first, I'll review early stage non-small cell lung cancer treatments, including a brief overview of local therapies. We'll talk about surgery versus radiation for stage 1 cancers. We'll discuss also the rapidly evolving field of systemic therapies for resectable disease. And then we'll transition and talk about advanced non-small cell lung cancer systemic therapies in the form of chemo, immunotherapy combinations, as well as targeted therapy. And then we'll touch briefly at the end on therapeutic resistance and tissue agnostic therapies. So by way of a brief introduction, in the US, there are an estimated 230,000 new cases every year of lung cancer, and that accounts for over 120,000 deaths each year. And still, lung cancer remains the leading cause of cancer-related deaths in the US as well as worldwide. About 85% of lung cancers can be classified as non-small cell lung cancers, histology such as adenocarcinoma, squamous cell. And most of these patients, unfortunately, still present with advanced stages of disease when curative approaches are typically not possible. So for many years, the standard of care for advanced lung cancer was chemotherapy doublets, mainly these platinum doublet chemotherapy regimens. And all of these chemotherapy doublets really performed relatively similarly in terms of overall survival shown at the top or time to progression shown on the bottom, with really overall poor outcomes on the order of months for our stage 4 patients. Back in 2006, the field shifted a little bit when a study demonstrated that the addition of bevacizumab or Avastin to chemotherapy had a marginal but significant survival benefit. So really for many years, platinum doublet chemotherapy plus or minus Avastin was the standard of care for advanced non-small cell lung cancer treatment. And all of that changed really in the last decade or two. And as we have been able to sort of expand our pillars of cancer treatment to include new paradigms such as targeted therapies and immunotherapies. When we talk about targeted therapies in lung cancer or in oncology in general, we're typically referring to small molecule inhibitors of a kinase that cancer cells really depend on for their proliferation. And when we're broadly talking about immunotherapies in lung cancer, we're typically referring to anti-CTLA4 or anti-PD-1 or PD-L1 agents, typically called immune checkpoint inhibitors, that serve to disinhibit the immune system through activation of T cells. So there's been a rapid pace of regulatory approvals in non-small cell lung cancer for both targeted therapies, shown in blue, as well as immunotherapies, shown in red. This really all started with the approval of crizotinib for ALK-positive non-small cell lung cancer in 2011, and erlotinib or Tarceva for EGFR mutant lung cancer in 2013, and a series of other targeted therapies and immunotherapies, which we'll review in detail today. So what changed? What has allowed this explosion of new therapies in the lung cancer space? Well, we used to classify lung cancer solely based on their histologic subtype. And over the last 2 decades, clinical genotyping efforts and translational research have really enabled this, we say, molecular stratification of lung cancers, namely in the adenocarcinoma space, based off of the presence of oncogenic driver alterations. And this has then spawned the development of targeted therapies matched to their respective oncogene. So over the last 20 years, the field has identified various oncogenic drivers in lung cancer, shown a few here shown in green. And shortly after their discovery, this was followed by regulatory approvals, shown in yellow, for these biomarker-dependent targeted therapies in patients with advanced disease. So when we're performing diagnostic workup of a patient presenting with a new diagnosis of lung cancer, we still do take histology certainly into consideration, but broad molecular profiling for actionable oncogenic drivers is absolutely critical. And why? This is because we now have this amazing arsenal of approved targeted therapies matched to their respective oncogenic driver that we use to treat patients. And going back to immunotherapy, this is another class of therapeutics, as I mentioned, that's been incorporated into the treatment paradigms in both early and late stage non-small cell lung cancer, as we'll talk about. Generally speaking, immunotherapy is comprised of this broad class of therapeutics that includes things like CAR T therapy, immune checkpoint inhibitors, cytokine-based therapy, antibody-based therapy, and vaccines. So currently, there are three sort of main checkpoint inhibitor strategies we use in lung cancer. That includes PD-1 monotherapy, so PD-1 inhibitors alone for biomarker positive disease, so that's PD-L1 high disease. We also have combination of immune checkpoint inhibitors, for example, CTLA-4 inhibition plus PD-1 or PD-L1 inhibition. And then we have combination strategies that include chemotherapy plus immune checkpoint inhibitors. And as a reminder, when we're talking about anti-CTLA-4 or anti-PD-1 or PD-L1 agents, these are antibodies that block signals that downregulate T cell activity. So by blocking these negative signals, these agents permit T cell activation and facilitate anti-tumor immunity. And the development and implementation of these targeted therapies and immunotherapies has absolutely been instrumental in reducing patient mortality from lung cancer. So for instance, one publication in NEJM a couple years ago showed that population level mortality from non-small cell fell sharply in 2013 to 2016. That's partially due to survival after diagnosis was substantially improved and partially attributed to the reduction in incidence, but also partially attributable to advances in these treatments, targeted therapies and immunotherapies, and incorporation into our treatment regimens. So first, let's talk about early stage non-small cell lung cancer. So first, we're going to review the approach to local therapies, for example, surgery and radiation, and then I'll review systemic therapies for early stage disease. So for local therapy for stage 1A non-small cell lung cancer, we're often thinking about modalities such as surgery and radiation. So as pulmonologists, you probably see more stage 1A patients than we do as medical oncologists. And so for early stage patients like this, multidisciplinary discussions are really critical to assess advantages or disadvantages of local therapy approaches. So the NCCN guidelines state that for stage 1A tumors, T1 and 0 tumors, surgery is still the standard of care for medically operable patients. However, for those medically inoperable cases, definitive radiation with SBRT or SABR can be considered. Advantages of radiation include things like it's non-invasive, there are mild or relatively few side effects, and long-term in-field local failure rates are comparable to that of wedge resections. Disadvantages of radiation include we don't have pathologic information, for example, for staging, and overall survival for SBRT has been shown to be worse than for surgical patients, but that, of course, might be confounded by other variables. So overall, we think about using radiation for early stage disease for these stage 1A cancers. We're really thinking about using this in sort of elderly patients or those with low pulmonary reserve. When surgery is performed for T1 and 0 patients for these early stage 1A cancers, what type of surgery is optimal? So while there's been a lot of buzz about this in the last couple of years, as we saw this large randomized non-inferiority trial that was published in 2023 by Al-Turki et al. That showed that in patients with these peripheral non-small cell lung cancers with a tumor size of 2 centimeters or less and pathologically confirmed node negative disease, these sublobar resections or wedge resections or segmentectomies were non-inferior to a lobectomy with respect to disease-free survival. All right, so what about systemic therapies in early stage non-small cell lung cancer? How do we incorporate things like chemotherapy, targeted therapy, and immunotherapy into our treatment paradigm? So there are three sort of main treatment strategies we consider in early stage disease. We think about adjuvant therapy, neoadjuvant therapy, and perioperative approaches. So adjuvant therapy, in which surgical resection comes first and then systemic therapy comes after, prioritizes, of course, the local approach with the knowledge perhaps that not all patients might be fit enough to make it to complete adjuvant systemic therapy. Neoadjuvant approach, in which we give systemic therapy first prior to surgery, prioritizes delivery of the systemic therapy, which comes first, with the risk that potentially all patients might not make it to surgical resection. And then we also have these newer perioperative systemic therapy regimens, or this sandwich approach, if you will, that delivers systemic therapies both before and after surgery. So first, let's talk about adjuvant therapies in early stage non-small cell lung cancer. So for many, many, many years, interestingly, the standard of care for early stage non-small cell lung cancer, mainly stage 2 and 3 disease, was to give adjuvant, so post-operative platinum-based chemotherapy. But you can see here from this LACE meta-analysis that oncologists love to cite, the absolute benefit here of adding chemotherapy is only 5.4% at 5 years, so pretty small. But with that being said, adjuvant chemo was the only systemic therapy that we had to offer patients until 2020, despite the advances of all these immunotherapy and targeted therapy agents that I mentioned earlier. So how did we think about moving up these agents from later stages of lung cancer to earlier stages of lung cancer? So one of the first studies that did that was a trial called the Empower 010 study. It was a phase 3 trial in which completely resected stage 1B to 3A non-small cell lung cancer patients were given adjuvant chemo and then randomized to either receive 1 year, essentially, of maintenance atezolizumab, immune checkpoint inhibitor, or best supportive care. And the study reported that adjuvant atezolizumab given after chemotherapy showed superiority in disease-free survival in the intention to treat population, those with PD-L1 greater or equal to 1%, with a hazard ratio of 0.66, showing that adjuvant immunotherapy after chemotherapy helps to prolong disease-free survival. So we were curing more patients. Subgroup analyses of the stage 2 to 3A patients showed that the benefit of adjuvant atezolizumab was greatest in the patients who had higher PD-L1. So that's shown here, PD-L1 of 50% or greater, so in PD-L1 high tumors. And it's a little bit less clear about how big the benefit is actually going to be in patients with the PD-L1 1 to 49% group. But ultimately, in 2021, the FDA did approve adjuvant atezolizumab following surgery, following platinum-based chemotherapy in patients with stage 2 to 3A non-small cell lung cancer, and those that had PD-L1 expression greater than or equal to 1%. So that's just one example. There are a variety of other trials that have been reported, and some of which are ongoing as well, looking at adjuvant immunotherapy after chemotherapy, after surgical resection. So for instance, based on data from the PEARLS study or KEYNOTE-091, the FDA approved adjuvant pembrolizumab in late 2023 after resection and platinum-based chemotherapy for tumors greater than 4 centimeters, irrespective of PD-L1. So to summarize sort of our adjuvant therapy updates in the early stage lung cancer space, so adjuvant atezolizumab and pembrolizumab are now approved as adjuvant therapies in stage 2 to 3 lung cancers. Overall survival really is the gold standard here for demonstrating benefit for adjuvant therapy, and we're still waiting for some of that data to mature. I would say our practice is to recommend adjuvant PD-1 in tumors, certainly with PD-L1 50% or greater, so these PD-L1 high tumors, and share decision-making conversations with patients about the pros and cons and so far lack of OS benefit in PD-L1 with the 1 to 49% subgroup. And we certainly are going to need more data biomarkers to help guide some of these decisions going forward. What about neoadjuvant approaches, so before surgery? So there are a myriad of studies looking at neoadjuvant chemo plus immunotherapy and other studies looking at these sandwich approaches, these perioperative approaches, given systemic therapy prior to and after surgery. So Checkmate 816 might sound familiar. This was really a seminal study published in 2022, which tested neoadjuvant nivolumab, an immune checkpoint inhibitor, plus platinum-based doublet chemotherapy versus chemotherapy alone, followed by surgical resection. And this is for, again, early stage disease 1B to 3A. And just notably, this is only given 3 cycles prior to surgery. You can have surgery and then all done. So no out back chemotherapy or immunotherapy. About 25% of patients at the time of surgery after receiving this neoadjuvant systemic therapy regimen had a complete pathologic response at the time of surgery, and only 2.2% in the chemotherapy group. And event-free survival data was in favor of the chemo plus Nivo versus chemo alone, with a median event-free survival of 31.6 months compared to 20.8 months. So in 2022, the FDA did approve this CheckMate 816 regimen of neoadjuvant Nivo plus platinum-based chemotherapy. What about perioperative approaches? So Keynote 671 was yet another study that looked at giving neoadjuvant chemotherapy, but in this study, they were also giving immunotherapy out back as well. So this was a phase 3 study that randomized patients to either receive neoadjuvant chemo or neoadjuvant chemo plus pembro, and this was for 4 cycles, followed by surgery, followed by either maintenance pembrolizumab, shown in green, or maintenance placebo. And this is testing really the efficacy of adding pembrolizumab, both neoadjuvantly as well as adjuvantly. Similar to CheckMate 816, Keynote 671 showed higher pathologic complete response with the addition of immune therapy up front and superior event-free survival with a hazard ratio of 0.58, so pretty impressive. We heard an update from ESMO in 2023 that overall survival was in favor of the pembrolizumab group, with a median overall survival still not reached in that combination group. So the FDA did approve Keynote 671 regimen, the perioperative approach for resectable non-small cell lung cancer for tumors greater than 4 centimeters or node-positive disease. So we now have at this point at least 5 randomized phase 3 studies that show superiority of neoadjuvant or perioperative chemo plus immunotherapy versus chemotherapy alone. So this is certainly now our new standard of care for surgically resectable non-small cell lung cancer. And I think a major takeaway point from this is that means referring to medical oncology prior to undergoing directly to surgery for early stage lung cancers. So we certainly need to see more data on PD-L1 negative patients and node negative tumors. And interestingly, there are some ongoing studies to investigate intensification strategies, particularly in patients who have residual disease at the time of surgery. Do we need to sort of escalate their treatment regimens if they have residual tumor at the time of surgery, despite giving them neoadjuvant therapy? All right, and let's transition now to talking about targeted therapy in early stage non-small cell lung cancer. This is also a rapidly progressing area. So biomarker testing now is also an integral part of the diagnostic workup in early stage non-small cell lung cancers. So that statement actually was not true when I started fellowship. And this goes beyond testing just for PD-1 or PD-L1 status and now includes evaluating for EGFR mutations as well as ALK rearrangements. So the ADAURA phase 3 study was a seminal trial which enrolled patients with EGFR mutant lung cancer, early stage lung cancers, stage 1B to 3A. They underwent a surgical resection. They needed to have negative margins, and they were treated plus or minus adjuvant chemotherapy, and then they were randomized to receive either osimertinib for 3 years or placebo. And my goodness, look at this incredible Kaplan-Meier curve. Based on this very striking disease-free survival data in patients with stage 2 or 3A disease and a recently reported overall survival benefit that I'm not showing here, osimertinib is certainly now the standard of care and is now approved for surgically resected EGFR mutant non-small cell lung cancer. What about other oncogenic drivers beyond EGFR? So EGFR usually sort of really paves the way, and other oncogenic driver studies sort of usually come after. So we saw the ALINA phase 3 study that tested for the first time an ALK inhibitor, alectinib, as adjuvant therapy for resected ALK-positive non-small cell lung cancer patients. So the ALINA study was actually a little bit different from ADAURA, and these differences certainly matter for us as medical oncologists, is that it randomized patients to either receive chemotherapy or targeted therapy alectinib after surgery. And we saw data reported out at ESMO 2023, which showed that disease-free survival benefit with a very striking hazard ratio of 0.24. And that ultimately did lead to its FDA approval about 1 year ago, that we now can use adjuvant alectinib after surgery for ALK-positive non-small cell lung cancer. So in summary here, there are now multiple trials that have shown that we do need to think about using immunotherapy upfront in early stage lung cancers. Excitingly, as I mentioned, osimertinib is now the first targeted therapy that was approved in many countries as adjuvant treatment for resected EGFR mutant lung cancer based on the ADAURA trial. And now, as I mentioned, we have approval for alectinib in early stage ALK-positive non-small cell lung cancer. And as I mentioned as well, there are approvals for neoadjuvant regimens, such as that CheckMate 816 regimen, and then these perioperative approaches, for example, Keynote 671. So now in the rest of the talk, I'll transition to talking about advanced non-small cell lung cancer. So this is patients with advanced or metastatic disease. We'll talk about systemic therapy updates in the form of immunotherapy combinations, targeted therapies, and then we'll briefly talk about acquired therapeutic resistance and tissue agnostic therapies. So initially, immune checkpoint inhibitors such as nivolumab, atezolizumab, pembrolizumab, these are PD-1, PD-L1 inhibitors. They were initially tested against the standard of care at that time, a sort of a wimpy chemotherapy agent that we typically use in the second line, docetaxel. And all of these showed superiority in improvements in overall survival in the second line setting. So what about in the first line? How did we then move them up to the first line? So a breakthrough study was published now almost 10 years ago in 2016 that finally moved immune checkpoint inhibitors to the first line, and that was Keynote 024. This was really a landmark phase 3 trial in the field of lung cancer that showed first-line pembrolizumab alone was superior to standard of care chemotherapy, again, platinum doublet chemotherapy regimen, in advanced non-small cell lung cancer for patients who had PD-L1 high disease, so greater than or equal to 50%. That showed a median progression-free survival of 10 months compared to 6 months. Long-term survival data from Keynote 024, again, showed a survival benefit of about 32% versus 16% at 5 years with a hazard ratio of 0.62. So therefore, in patients with PD-L1 high disease, we still often cite this study and use this treatment regimen for PD-L1 high patients. Pembrolizumab monotherapy alone is the preferred first-line therapeutic strategy. What about in combination with chemotherapy? So Keynote 189 was the phase 3 study that was published in 2018 that showed superiority of first-line pembrolizumab plus chemotherapy versus chemotherapy alone. And this was regardless of PD-L1 expression, as I'll show you. So overall survival data for the intention to treat population for Keynote 189, the chemo plus pembro group shown here in green performed better with 69% survival rate at 1 year versus 49%. When broken down by PD-L1 status, as we know that this has tracked across multiple studies, there you can see the TPS score less than 1%, the 1 to 49%, and the greater than 50%. You can still see that the magnitude of benefit was greatest by virtue of that separation of the Kaplan-Meier curve for the 50% or greater group, but that the less than 1% PD-L1 group still derived benefit from the addition of pembrolizumab. And so as a reminder, the tumor proportion score that we're talking about here is the number of PD-L1 positive tumor cells divided by the total number of all tumor cells multiplied by 100. So there are multiple other phase 3 trials at this point that have demonstrated efficacy of chemotherapy plus immunotherapy in different contexts. A few of them are listed here for your reference. Most notably, as I mentioned, we use that Keynote 189 regimen for adenocarcinoma, and we typically use the Keynote 407 regimen for advanced squamous cell lung cancer. So when thinking about sort of the treatment algorithm for advanced non-small cell lung cancer, we of course obtain a tissue biopsy at the time of diagnosis. We always perform molecular genotyping to evaluate for oncogenic drivers. And if there is a driver, of course, targeted therapy is typically the standard of care, and we'll talk about that momentarily. And if there's no oncogenic driver alteration, we stratify by PD-L1 status. For PD-L1 50% or greater patients, we typically can use PD-1 or PD-L1 monotherapy. For PD-L1 less than 50%, combination of chemotherapy plus immunotherapy is used. So times used to be simpler. They got a little bit more complicated over the last few years as we've seen multiple other approvals of different combination strategies for advanced non-small cell lung cancer. And these come in the form of either combinations of chemotherapy plus immunotherapy or dual immunotherapy regimens alone. So for example, I list a few of them here in the FDA approval. So CheckMate 9LA is 2 cycles of chemotherapy plus dual immunotherapy in the form of ipilimumab plus nivolumab for advanced non-small cell lung cancer. The Poseidon regimen is 4 cycles of chemotherapy plus durvalumab and tremelimumab, so CTLA-4 inhibition and PD-1 inhibition. And CheckMate 227 is dual immunotherapy alone without chemotherapy for advanced non-small cell lung cancer. So the good news for us as medical oncologists is there now are multiple options across different PD-L1 spectrum for patients. And I'd say really the challenge here is that we don't have great head-to-head comparisons. So we often have to sort of carefully consider certain subgroups of patients, for instance, those with molecular alterations that are known to be sort of resistant to single agent immune checkpoint inhibitors. Of course, we have to factor in toxicity, especially when we're talking about a quadruplet regimens, for example, 2 chemotherapies and 2 immunotherapies. And speaking of toxicities, I did want to take a moment to point out that, of course, we do observe a myriad of immunologic toxicities or these immune-related adverse events that can be seen with immune checkpoint inhibitors. Managing these immune-related adverse events is certainly a multidisciplinary effort across our hospital system. I often lean and collaborate with colleagues across all different fields, GI, cardiology, pulmonary, rheumatology, et cetera, to assist in the management of these complicated adverse events. So to summarize here, 5-year overall survival rates among patients with advanced non-small cell lung cancer treated with chemotherapy plus immunotherapy now are on the order of 20%, so much better than we were doing a few decades ago. And notably, we do stratify based off of PD-L1 status. For PD-L1 50% or greater, we often consider single agent immune therapy. For PD-L1 less than 50%, we consider combination regimens, for example, chemotherapy plus immunotherapy. In particular, I do want to highlight as the field is changing, we do consider PD-1 and CTLA-4 inhibition plus or minus chemotherapy in select cases. For example, those patients that have PD-L1 less than 1%, or those with certain molecular alterations, for example, those with KRAS, KEAP1, STK alterations that are associated with poor responses to immune checkpoint inhibitor monotherapy. So certainly still a nuanced discussion. In our last couple of minutes, I want to talk about targeted therapy in advanced lung cancer. So we know that cancer is a disease of the genome, right? That cancers are largely a consequence of DNA damage with mutations and rearrangements that result in uncontrolled cell proliferation. We know that inherited genomic changes can cause or influence cancer risk. And really, if we look at tumors, the majority are known to contain at least one identifiable alteration in the genome. So now we routinely evaluate for diverse sets of genomic alterations in lung cancer. I'm going to highlight a few key examples, things that are actionable here. So we evaluate for genomic translocations in which a piece of the chromosome is broken off and reattaches to a different chromosome so that gene A and gene B are fused to create an oncogenic fusion protein. In lung cancer, we can observe these fusions involving genes such as ALK, ROS1, RET, or NTRK. There are others. We also evaluate for single nucleotide mutations in genes like KRAS, G12C, BRAF, V600E, or EGFR, L858R. And then we evaluate for these insertions or deletion events, these indels, such as in the case, for example, EGFR or HER2 and exon 20, or MET in the case of MET exon 14 skipping alteration. So again, I just want to make this critical point that when we're performing diagnostic workup of a patient presenting with a new lung cancer, we certainly do take histology into consideration, but molecular analysis for these actionable oncogenic drivers, some of which I just mentioned, is critical because we have this amazing arsenal of FDA-approved targeted therapy agents matched to the respective oncogene that we use to treat patients. So by way of just a brief case, one of my patients, Mrs. Z, is a 55-year-old female never smoker, presented with dyspnea and exertion, a really nagging dry cough, fatigue, and weight loss. She had scans that certainly were suspicious for metastatic lung cancer. And when she had a biopsy, it confirmed invasive lung adenocarcinoma, PD-L1 less than 1%, and she had a mutation in EGFR at L858R. She was started on a 3rd-generation EGFR inhibitor called osimertinib, which is an oral targeted therapy agent that we've talked about. And within 6 weeks, she had significant symptomatic relief and an excellent radiographic response to therapy. So it's really interesting to go back and think about the first EGFR inhibitors were evaluated over 20 years ago in the early 2000s in an unselected patient populations, meaning all comers with lung cancer, not necessarily those that had EGFR mutations because we didn't know any better. Trials at that time were largely underwhelming, but a few keen oncologists here in the Boston area went on to describe that patients who had substantial responses, those patients who were responding to these EGFR inhibitors, were those that actually had EGFR mutations. The story was actually written up in the Boston Globe in 2003 with the title, "A Drug That Works for Some." And this was really the start of a revolution in lung cancer treatments in being able to sort of tease out who was going to respond to certain types of targeted therapy. As a next step, trials were designed in selected patient groups. For instance, patients who harbored EGFR mutations in their tumors were those that responded to EGFR inhibitors with decreases in their tumor size. And at that time, historically, again, this is going back about 15 years, the biggest question became whether patients with EGFR mutant lung cancer, for instance, should receive truly this oral targeted therapy agent, or should they go on to receive first-line standard of care chemotherapy, which had been standard of care for decades prior. So this is a compiled list of phase 3 clinical trials of EGFR tyrosine kinase inhibitors, or these TKIs, all of which showed superiority of the targeted therapy agent compared to chemotherapy in the first-line setting. So I say these trials were really practice changing for the field, as it taught us that patient group with EGFR mutant lung cancer should not get first-line chemotherapy, but in fact should get first-line targeted therapy. And so over the decades, we've seen successive generations of EGFR inhibitors that have been developed with the goal of improving selectivity against EGFR mutant protein itself. And so we have, for example, first generation erlotinib, gefitinib, second generation afatinib, dacomitinib, and then, as I mentioned, our standard of care osimertinib is our third generation EGFR TKI. So osimertinib is a preferred first-line EGFR TKI for EGFR mutant lung cancer with classical EGFR mutations. It was approved by the FDA in 2018 based off of the seminal FLAURA trial, which demonstrated superiority of osimertinib compared to earlier generation EGFR TKIs with a median progression-free survival of about 1.5 years. And regardless really of subgroup breakdown, osimertinib was superior compared to earlier generation TKIs. So this was actually a relatively straightforward story for EGFR up until about 1 year ago. It was clear that we should all be using osimertinib as first-line therapy, but given that we were traditionally sequencing first osimertinib, and then when patients relapse after about median PFS 1.5 years, they usually go on to receive chemotherapy in the second line, but there were a lot of discussions about whether we should be combining targeted therapy and chemotherapy up front, whether that would be synergistic. So the FLAURA2 study was a large phase 3 trial looking at patients with EGFR mutant lung cancer who either received osimertinib alone in the first line or osimertinib plus chemotherapy up front, followed by this maintenance phase of osimertinib plus pemetrexed for adenocarcinoma patients. And the primary endpoint was progression-free survival. So FLAURA2 technically met its primary endpoint with improvement in PFS for osimertinib plus chemotherapy, with the median PFS being improved by about 9 months compared to monotherapy. So is this the new standard of care? It's still debatable, I'd say. The addition of chemotherapy to osimertinib did improve median PFS, but it certainly comes at the cost of increased toxicities, for example, hematologic toxicities we see with chemo fatigue and more frequent clinic visits. Overall survival analysis was immature, but it did not appear to be improved with the immature data that we saw. I'd say in my clinic, we are using or considering or having these shared decision-making conversations with patients about using chemotherapy plus osimertinib up front, particularly in those patients with really high burden of disease or particular high-risk subgroups, for example, those with CNS metastases. But we certainly need better tools for risk stratifying patients to understand whether they really should be receiving this combination therapy up front. So what other tools am I talking about? There are some really interesting trials looking at this. So wouldn't it be sort of nice if we knew which patients were more likely to relapse early on first-line osimertinib and really might benefit from upfront chemo plus targeted therapy? So the EGFR Shetter study, as it's called, is evaluating circulating tumor DNA clearance after starting on osimertinib, for instance, for after 3 cycles. If one is persistently positive in terms of their circulating tumor DNA and our ability to detect the EGFR mutation peripherally, these patients are randomized to receive either osimertinib alone or osimertinib plus chemotherapy. And I'd say there are also other novel agents being developed and some recently approved for EGFR mutant lung cancer beyond osimertinib that I've been talking about for the last few minutes. For example, the Mariposa trial evaluated 2 novel agents, an EGFR TKI called lazertinib and a bispecific monoclonal antibody targeting MET and EGFR called amivantamab. And this combination met its primary endpoint for first-line treatment in EGFR mutant lung cancer and led to an FDA approval late last year. So amazingly, I hope I've impressed upon you the point that our arsenal of targeted therapies goes well beyond just EGFR. And I'm just going to sort of briefly in the next couple of minutes summarize additional approvals that we have in the targeted therapy space, both approved by the FDA as well as the EMA. And again, I want to emphasize it is a formal NCCN recommendation that physicians perform broad molecular profiling at the time of diagnosis in patients with advanced lung cancer. And this goes beyond testing for EGFR, but extends to things like ALK, ROS1, KRAS, BRAF, NTRK, MET exon 14 skipping, RET, and HER2. So ALK, I want to mention briefly, is another oncogenic driver. Similar to EGFR, I'm showing the different generations of ALK inhibitors that have been developed. And as we've sort of gotten better and better inhibitors, we've seen increased potency against the target ALK. We've seen better CNS penetration and broader coverage against resistance alterations. This is the summary of second generation and third generation ALK inhibitors. So very impressive data we saw from our CROWN trial published in 2020 that lorlatinib, a third generation ALK inhibitor, was superior to crizotinib, a first generation drug, with a median progression-free survival still not reached at 3 years, and actually more recently reported 5-year data. ROS1 fusions are another oncogenic driver in lung cancer, representing about 2% of non-small cell lung cancer cases. There are a variety of ROS1 targeted therapies that have been developed and tested in these patient populations. Some of these actually might look familiar to you. Crizotinib and lorlatinib both work on ALK and ROS1, but it really is important to know that not all ALK drugs work on ROS1 and not all ROS1 drugs work on ALK. RET fusions represent another subset of lung cancer. We saw from the Libretto trial and the ARROW study that these RET TKIs, salperquetinib and pralsetinib, are certainly clinically active with a response rate of about 80% in the treatment naive setting, as well as in the pre-treated setting as well. So these are standard of care first-line therapy drugs. Now, NTRK fusion, we have larotrectinib, again showing response rates in the 70%. For MET exon 14 skipping alterations, these represent about 3 to 4% of non-small cell lung cancer. We have targeted therapies such as capmatinib that are efficacious in the treatment naive setting, as well as the previously treated populations. We have BRAF and MEK inhibitors, response rates in about the 60% range. And we have KRAS G12C inhibitors, for example, adagrasib, with response rates in the 40% and are currently approved in the second line. So it's really been remarkable to sort of witness the shift in our treatment paradigm from giving histology-specific chemotherapy to now being able to assay for these molecular driver alterations, and if present, considering these targeted therapy options, many of which are oral. And I do just want to point out, too, that retrospective studies have shown an improvement in overall survival for these advanced lung cancer patients who actually go on to receive the matched targeted therapy. And that can either be testing with tissue, or even it's been shown with retrospective analysis of patients who have positive circulating tumor DNA without necessary tissue sequencing. So all of this is to say that we've seen population level mortality from lung cancer in the US fall sharply, and survival after diagnosis has been improved substantially. And part of this can certainly be attributable to targeted therapies and immunotherapies that we now have available for our patients. And just in the sake of time, I'm going to sort of advance here and talk briefly about acquired resistance. When we think about acquired resistance to lung cancer treatments, these targeted therapies, we think about on-target mechanisms, and we think about off-target mechanisms in which bypass pathways or lineage transformation can serve to subvert the dependency on the initial oncogenic driver. So a very active area of investigation, for example, in EGFR mutant lung cancer, is trying to uncover the landscape of resistance mutations that occurs in patients who progress on these targeted therapies. Some patients will develop on-target mutations in EGFR. Some patients will develop off-target bypass pathway alterations, and some patients will develop lineage transformation, for example, to small cell lung cancer. So there are clinical trials, multiple clinical trials in place that are enrolling patients with specific identifiable resistance mutations after osimertinib to evaluate if rational combination therapy is effective. Similarly, in ALK-positive lung cancer, about 20 to 40% of patients will have on-target ALK mutations that would be identified at the time of resistance, but most patients will have what we say ALK-independent mechanisms of resistance in which bypass pathways are upregulated. We've learned a lot about doing tissue and liquid biopsy analysis from these patients relapsing on their targeted therapies, and we can see a tremendous array of mutations, for example, that occur in the ALK gene itself. And so, for instance, that is why better and more selective targeted therapies have been developed. I mentioned before our third generation ALK inhibitor, lorlatinib, is approved for progression on prior ALK TKIs. But unfortunately, what we're learning is that we can have the best inhibitor ever but resistance will always essentially develop. So patient biopsies, for example, reveal compound ALK mutations, shown here in the dark blue part of this chart, which are 2 or more mutations in the ALK gene itself in cysts, which are unfortunately refractory to all FDA-approved therapies to date. So we do have clinical trials in place. For example, Nuvalent 655 is an investigational agent in this space. It's a 4th-generation drug being tested in the ALCOVE global study. And we did see interim results reported last year showing activity both in pretreated patients and sort of perhaps better activity in those that have these compound mutations. So a major point I want to make here is that biomarker testing in advanced disease at the time of diagnosis is critical, and at the time of disease progression is also critical to help guide treatment selection and consider enrollment on clinical trials. And in my last minute, I know I'm just 1 minute over time, so let me try and wrap up here. We think about this targeted therapy movement as not just confined to lung cancer alone. In fact, the field of oncology has really started to test these agents in a tissue agnostic fashion. And what I mean by that is that we can now treat cancers based on their genetic and molecular features without necessary regard to the cancer type or where it started in the body. So, for instance, those patients with NTRK fusion positive cancers, regardless of tissue of origin, whether it be lung or thyroid, can be treated based on their cancer genomic features, for example, the NTRK fusion. So here I'm showing a timeline of FDA-approved tissue agnostic therapies that can be used to treat cancers based on molecular features rather than tissue of origin. So that includes things like pembrolizumab. We've talked about immune therapy for MSI high or TMB high tumors, larotrectinib or entrectinib for NTRK fusion positive tumors, dabrafenib trametinib for BRAF V600E cancers, and selpercatinib for RET fusion positive cancers, again, irrespective of tissue of origin. And we just saw our first sort of tissue agnostic approval for an antibody drug conjugate, this trastuzumab deruxtecan, just last year for metastatic HER2 positive cancers. So to summarize, we've talked about early stage lung cancers, local therapy options, radiation versus surgery. We talked about early stage systemic therapy options in addition to surgery, so things like chemotherapy, immunotherapy, targeted therapy, and the different contexts in which we now have data to support using them either adjuvantly, neoadjuvantly, or perioperatively. We talked about advanced non-small cell lung cancer, immunotherapies, and targeted therapies. And then we touched on acquired resistance and tissue agnostic therapies. So main takeaway points are listed here for your reference. And I'll wrap up and say thank you for your attention. Happy to take any questions in the Q&A.